faculty with us, Dr. Amirtha Thampi, who is a palliative care physician and also having 10 years of experience in palliative care. She did her certificate course in pain and palliative medicine from Pallium India, and also she did her fellowship in pain and palliative medicine from Pallium India. So she is a well-versed person in this field. Now she is heading the clinical services of Pallium India. So, Madam, welcome and over to you.
Thank you, Sangeet and Shiva, for that kind introduction. Good afternoon, all. So, as Shiva has already mentioned, today we'll be talking about introduction to pain. So, what is pain? Pain has got different ways of expressions. As you can see, different people respond differently to pain. So, let us see what is pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So, this was a definition that was previously on. Now, the International Association for Study of Pain in 2020 has reworded the definition, and that says that it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So, what does that mean? So, pain, I think most of you or all of you would agree that pain is an unpleasant experience. So, nobody is happy to have pain. So, it is an okay. So pain is an unpleasant sensory and emotional experience. So now it is not only a sensory experience, but it has also an emotional component to it. What does that mean? So that means that a patient who is in pain in different emotional situations have different pain experiences or pain perceptions. For example, a patient who is in a very good mood might not perceive pain the same way when a person having the same kind of pain in a low mood or a sad mood might perceive. So that is what is meant by that. The pain has got an unpleasant and emotional experience, or it has got an emotional component. And what is that associated with? It could be associated with either actual or potential tissue damage or described in terms of such damage. So this pain could be due to actual tissue damage. So actual injury to the tissue, maybe due to a cut, maybe due to a burn, the actual tissue damage can be painful. Also, the stimulus that has the potential to cause tissue damage. For example, you might have seen patients with periocclusive vascular disease. So due to the occlusion of the vessels, they will have severe pain. So there, we don't have an actual tissue damage there, but if this occlusion stands or prolongs for a long period of time, what would happen? It can result in tissue damage. So there, the stimulus has the potential to cause a tissue damage. And or resembling that associated with. What does that resembling that means? So there are situations where we cannot identify the organic cause of pain, but the patient says that there is pain. Such situations also, the pain is, we have to believe the patient that the patient is in pain and that pain is also real. So that is what is meant by resembling that associated with actual or potential tissue damage. So pain is an unpleasant sensory and emotional experience. So it is an unpleasant experience. Nobody likes to have pain, and it has a sensory and an emotional component to it. which could be either directly associated with or it can resemble that associated with actual tissue damage or a potential tissue damage or a stimulus that has the potential to cause tissue damage. And this was the definition put forward by the International Association for Study of Pain. So, pain is what the patient says it hurts. So, always believe the patient about his or her pain. So, many situations when patient come to you, we might feel confused. Is the patient really in pain? We might not be able to find the cause of the pain, but we need to believe the patient and address the pain and try to understand and evaluate the pain and assess more on the pain. So, first and foremost, it is very important to believe the patient about his or her pain. What is total pain? You might have gone through the total pain concept in your previous sessions. Any thoughts? Anyone would like to unmute and respond? What is total pain concept? If you want to type in the chat box, you can type in the chat box also.
Unpleasant sensation.
Yes, pain is an unpleasant sensation. How is it different from total pain? What is total pain? Yes, we are getting more responses in the chat box. Yes. So, who put forward this concept? Total pain concept was put forward by Dame Cicely Saunders. So, she was a British nurse who was also a social officer. So, she has been working in multiple fields. She was a social worker. Then she turned a physician, and also she was a writer. So her famous words, "You matter because you are, and you matter to the last moment of your life." These words by Dame Cicely Saunders, who put forward the total pain concept, is always remembered in palliative care. So the total pain concept, what does it explain? It is not just a physical experience. Pain always creates an emotional response. It has a social impact and it has a spiritual meaning. And always remember, pain causes more pain and all pains are real. The famous words by Dr. M.R. Rajagopal, our founder chairman. So all pains are real and believe your patient. So I'll be keeping on telling you that believe your patient about the pain, because that is very important, that you believe the patient and try to understand more about the patient's pain. To understand or explain the total pain concept, we have the physical component, the social component, psychological component, and the spiritual component to the total pain concept. And the physical components include, so other than pain, the patient might be having other symptoms also. There could also be undesirable effects of treatment, insomnia, chronic fatigue. All this would include the physical component of pain. What does the psychological component include? The patient might be angry at delay in diagnosis. They might feel that if this was diagnosed earlier, the situation could have been better. Maybe angry at the therapeutic failure. There could be disfigurement, fear of pain, fear of death, feeling of helplessness. All these are some of the psychological components of total pain. And the social components include, obviously, there would be worry about the family and finances, the loss of job, prestige, and income, loss of social position, the primary breadwinner of the family losing role in the family, feeling of abandonment and isolation. And of course, there is a spiritual component also to this, which, why has this happened to me? Why does God allow me to suffer like this? What is the point of it? Is there any meaning or purpose in life? So is it a punishment to me? Can I be forgiven for past wrongdoing? So many people in their spiritual pain, they ask us, has the God really punished? Or is it due to my sin that this has occurred to me? So all those are the spiritual components. So when you manage pain, all the four components of pain should be addressed if you need to provide a satisfactory symptom control or pain relief to the patient. The four components of total pain concept should be addressed. Now, just to familiarize you with some of the terminologies to understand more about pain. What is a noxious stimulus? A noxious stimulus is one that is potentially or actually damaging to the body tissue. It can actually produce a damage to the body tissue, or it has the potential to damage the body tissue. So that is a noxious stimuli. What is a nociceptor? A receptor preferentially sensitive to tissue trauma or to a stimulus that would damage tissue if prolonged. So the nociceptors are usually receptors. They are found in the peripheral nerve endings, and they are when there is a tissue injury or trauma, or when a stimulus that has the potential to cause tissue injury acts, these receptors, the nociceptors, are getting sensitized in the peripheral nerve endings. So what are nociceptors? These are receptors in the peripheral nerve endings that get sensitized due to a tissue damage or to a stimulus that has the potential to cause tissue damage when it lasts for long. And what is nociception? So the process of conveying information about the tissue damage to the central nervous system, that is known as nociception. So a tissue damage has taken place, and this information has to go to the central nervous system. And this information, process of conveying this information to the central nervous system, that is known as nociception. So what is dysesthesia? Dysesthesia is an unpleasant, abnormal sensation. And paresthesia means it is an abnormal sensation, but dysesthesia is an unpleasant, abnormal sensation. And what is allodynia? So these terminologies might come in between, so you need to know about these terminologies. Allodynia, it is a pain caused by a stimulus that does not normally provoke pain. So a stimulus that does not normally causes pain, that stimulus, if it produces pain, it is known as allodynia. For example, some people say that they have pain on touch. Maybe due to the fan, they get pain. Due to the fabric falling on their body, they get pain. Yes, wearing dress, clothing produces pain in some people. That is allodynia. It is the pain that is caused by a stimulus that does not normally provoke pain. And what is hyperalgesia? It is an increased response to a stimulus that is normally painful. So this stimulus can normally provoke pain, but here there is an exaggerated response or an increased response to the stimulus. That is known as hyperalgesia. Moving on to the pathophysiology of pain. So we already mentioned that there is nociceptors or the receptors which are present in the free peripheral nerve endings. Free nerve endings, we have the nociceptors. These are sensitive to the tissue damage. So when a tissue damage or a stimulus that has the potential to tissue damage acts on the peripheral tissue, or when there is a tissue damage, what happens? These receptors gets activated and a stimulus is being formed. This pain stimulus is being transmitted through the afferent nerve fibers to the dorsal horn of the spinal cord. And from the dorsal horn of the spinal cord, through the lateral spinothalamic tract, you can see that there is a lateral spinothalamic tract that through this lateral spinothalamic tract, these pain impulses reach the thalamus. And from the thalamus, they reach the somatosensory area of the cerebral cortex, where pain is perceived. So, the peripheral nerve endings or the nociceptors get stimulated due to the tissue injury and the impulses are generated. These impulses are carried through the afferent nerve fibers to the dorsal horn of the spinal cord. And from the dorsal horn of the spinal cord through the lateral spinothalamic tract, what happens? These impulses reach the thalamus. And from the thalamus, they reach the somatosensory area of the cerebral cortex where pain is perceived. So this is very simply or in very simple language, I have mentioned the pathophysiology of pain. So what is nociception? Can somebody tell me what is nociception? We have just now learned about nociception. Can somebody unmute and talk or type in the chat box? What is nociception?
The damaged cells send out signals to the brain that there is a tissue injury.
Very good. Thank you, Shani, for that. So exactly the information that there is a tissue damage that is being the process of sending this information to the central nervous system is known as nociception. So there are several, yes, Bharati, thank you for that. So there are different steps involved in the process of nociception. That is transduction, transmission, modulation, and perception. So these are the various steps involved in the process of nociception. So what is transduction? So there is a local tissue injury. What happens when there is a local tissue injury? There will be release of the inflammatory mediators. Bradykinin, histamine, prostaglandins, these mediators gets released and they stimulate the peripheral nociceptors and cause peripheral sensitization. And there will be a formation of impulse. These impulses are carried to the dorsal horn of the spinal cord. And from there, the impulses reach the thalamus through the lateral spinothalamic tract. And from the thalamus, they reach the cerebral cortex and the limbic system. So, what is transduction? So, transduction, the tissue is exposed to a noxious stimuli. We said that there is, what happens? There will be release of chemical substances like bradykinin, histamine, all this gets released. There will be a process of depolarization and repolarization and an impulse formation occurs. So that is transduction. A tissue damage occurred, then in response to the tissue damage, what happens? There will be release of chemical substances and these substances sensitizes the receptors and causes through depolarization and repolarization and there will be impulse formation. That is transduction. So once the transduction, what is the next step? After transduction, what happens? Can somebody unmute and tell me what is the second step in nociception?
Is it transmission?
Yes. Thank you, Shani, for that. It is transmission. So the transduction. So now the impulses have been formed. Now the formed impulses from the nerve endings are carried to reaches the spinal cord, then to the thalamus, and then to the cerebral cortex. So that is through transmission. So what is the next step that we said? Nociception. There are 4 steps in nociception. First was transduction, transmission. What is the third step?
Modulation.
Modulation. Thank you for that. So there are 3 mechanisms involved in modulation of pain pathway. So modulation of pain pathway can occur either through the descending pain inhibiting system. It can be through the endogenous opioids like endorphins and enkephalins, and also other physical, psychosocial, spiritual sufferings. So pain modulation can occur through 3 mechanisms. So we have already said that there is an emotional component to the pain and emotion. So the other physical factors as well as the psychosocial spiritual sufferings can modulate pain. So we already said that the emotional situation of the patient can influence the pain. It can modulate the pain. Then the other two systems, what is descending pain inhibiting system? So in our body, we have as we talked about the ascending pain pathway, we have a descending pain pathway also. This descending pain inhibiting system, what does it do? This pathway, through its biogenic amines, the neurotransmitters like serotonin and noradrenaline, what does it do? It inhibits the transmission of pain impulses. So this is a descending pain inhibiting system. So through these neurotransmitters like serotonin and noradrenaline, what does it do? The pain transmission of the pain impulses are being inhibited. And that is how they modulate the pain pathway. So this is through the descending pain inhibiting system. Then we have the endo and exogenous opioids. What are exogenous opioids?
From outside the body, externally given.
Yes, exactly, Shami. So opioids that we provide from outside the body. What does the opioids do in our body? So they act on the pain pathway and inhibit the transmission of pain impulses, and thereby they produce the pain relief. So these are exogenous opioids, means these are opioids which we give externally to the body for pain management as analgesics. For example, exogenous opioids includes, can somebody give me an example of an exogenous opioid?
Morphine.
Yes, morphine, fentanyl, methadone, tramadol, all these are exogenous opioids that we provide as medications for pain relief to the patient. Similarly, our body produces some endogenous opioids also. This includes enkephalins and endorphins. Endorphins and enkephalins are the endogenous opioids produced by our body that can modulate the pain. So, the pain modulation takes place basically by three mechanisms: through the descending pain inhibiting system, through the endogenous opioids, and also through the other physical symptoms or psychosocial-spiritual sufferings. The pain modulation takes place. What is the next step?
Perception.
Perception. So the impulses that have been transmitted is being perceived by the somatosensory area of the brain. There will be what happens? There will be conscious experience of pain. So the patient feels the pain or perceives the pain. That is perception. That happens in the somatosensory area of the cerebral cortex. So this is nociception. There are 4 mechanisms involved in nociception, and that is transduction, transmission. Yes.
Modulation and perception.
Yes. So now the pain is being perceived. What is central pain or central sensitization? When the pain is experienced over a prolonged period of time, what happens? The sleeping nociceptors, which are usually not sensitive to this pain impulses, they get activated. They get sensitized, and even the adjacent neurons get stimulated, and there will be recruitment of more of neurons, and the pain gets increased in severity and it will be more widespread. So since more neurons gets recruited, even with a small pain impulse or a less intensity of pain impulse, there will be widespread pain. Since the adjacent nociceptors are all getting sensitized, there will be increased pain. So this is central sensitization. Moving on to the types of pain. So there are there are different ways in which pain can be classified. So here we are talking about nociceptive and neuropathic pain. What is So types of pain, nociceptive and neuropathic pain. Nociceptive pain, again, it can be somatic and visceral pain, and neuropathic pain can be due to the nerve compression or it could be due to the nerve injury. And what is nociceptive pain? The pain that is due to the injury of the tissues or due to the stimulation of the peripheral nerve endings. It is called nociceptive pain. It can be somatic when it is due to the injury of the bones and soft tissues. It is somatic, and it is visceral when the deep tissues are in deep organs are involved. It could be capsular, bowel, and cardiac. So that is nociceptive pain. And in nociceptive pain, the sensory nerves would be functioning normally. The nerves are not, sensory nerves are not, okay. The sensory nerves are functioning normally. So the nerves are not affected in nociceptive pain. And the nociceptive pain, the sense pain is due to the injury of the tissues. So what is not? I hope all of you are with me.
Yes.
Okay, thank you. Thank you for confirming that.
Yes. Yes, ma'am.
Okay. So what is neuropathic pain? So what is neuropathic pain? Neuropathic pain means the pain usually occurs along the distribution of the nerve, and it is a burning or a stabbing or lancinating or stinging type of pain. Deep ache. The patient might say there is deep ache. And there will be abnormal sensations associated with neuropathic pain. What is allodynia? Can somebody unmute and talk?
Abnormal sensation when you don't expect, like a fan, the wind from a fan, or maybe a dress on a body. Normally, it should not cause pain, but when
Yes.
that causes pain, you call it allodynia.
Yes, Shani. Thank you for that. So, the stimuli that is not normally painful that produces pain. That is known as allodynia. For example, it could be due to touch. If touch produces pain, fabric falling on the fabric falling on the skin produces pain, could be due to the fan, wind from the fan causing pain. That is allodynia. So abnormal sensation the pain due to a stimulus which normally does not evoke pain. So what is hyperalgesia? Can somebody tell me what is hyperalgesia?
Nausea and vomiting.
Hyperalgesia.
When the pain is exaggerated.
Yes. So it is a normally painful stimuli, but it produces an exaggerated or increased response. So that is called hyperalgesia. So both these are features of neuropathic pain. So in neuropathic pain, we can have there would be abnormal sensations, which could be either increased sensations like allodynia and hyperalgesia, or decreased sensations like numbness. And here the sensory nerves mostly functions abnormally, and that is why this abnormal sensations occur. So that is neuropathic pain. What is visceral pain? So it is a poorly localized pain. Usually the patient will not be able to locate exactly where the pain is. They might tell you all over the abdomen there is some kind of pain that comes off and goes off, intermittent kind of pain. In between there will be a colicky type of pain or cramping type of pain. Such pain, it is known as visceral pain. It is usually due to the pain in the deep organs that causes visceral pain. And usually that is accompanied by nausea and vomiting. The patient might have nausea and vomiting when there is visceral pain. So it is dull type of pain. It is poorly localized pain. The patient will not be able to point the exact location of the pain. That is visceral pain. So, what is somatic pain? Somatic pain, the patient is able to clearly tell you, point the location or the site of pain can be well pointed. That is precisely localized pain. That is called somatic pain. And usually the quality would be like intense, constant pain. So visceral pain it is intermittent kind of pain, whereas somatic, it is a constant pain. It is a sharp, knife-like pain, aching or throbbing kind of pain. And usually the muscle, there will be local guarding and rigidity. So this usually the somatic pain is associated with muscle injury. So there will be guarding and rigidity of the muscles, and it gets worsened after coughing or position changes. Usually this somatic pain may be due to some infections or inflammations or chemical irritations. So that is somatic pain. So visceral pain, how can you differentiate between visceral pain and somatic pain? Can somebody unmute and tell me one difference between visceral pain and somatic pain?
Visceral pains is like internal organ colic pain or like that, having vomiting also.
Yes, very good. So it is a deep pain, deep ache that is intermittent in nature. It comes and goes off, and the patient will not, it is not localized. It is poorly localized pain. The patient will not be able to correctly point out the site of pain. Whereas, what about somatic pain?
Pain is localized pain.
Yes, it is a well localized pain. It is a constant pain. And there could be, it is mostly associated with infections and inflammations and chemical irritations. And there could be muscle guarding or rigidity associated with the somatic pain. So there is another classification of pain, which is acute pain and chronic pain. Yes. So what is acute pain? So it is a transient pain. So when I say acute, it's only for a short duration, acute pain. And it is always positive in nature. What does that mean? So when there is a pain, it draws our attention. It is like a preventive mechanism. Yes. So it is a positive pain, and it will have associated tachycardia, tachypnea, shunting of blood from viscera to muscles, increased sweating, pupillary dilatation. All this would be associated with acute pain. Whereas in case of chronic pain, it is a persistent pain. It is lasting since long, and it is a negative pain. It does not have any useful purpose. This pain is always disturbing the sleep of the patient. It is causing anorexia, no pleasure in life. It can also cause constipation, and in fact, it can result in personality change and lethargy to the patient. So that is the main difference between the acute and chronic pain. So chronic pain, it is a negative pain. The pain doesn't have any useful purpose. So it is always disturbing to the patient, and the patient is unable to carry out his or her daily activities. So that is chronic pain. Now, just to understand, what are the causes of pain in cancer? So it could be either disease related, so treatment related, debility related, or it could be due to comorbidities. So if it is disease related, it could be due to the soft tissue infiltration, visceral involvement, extension to the bone, neuropathic pain. All this could be due to the disease itself. It could also be due to the treatment related pain, that is due to the surgery, chemotherapy, radiotherapy. As a result of this treatment, patients can develop mucositis. So all this is treatment related issues that can cause pain in cancer patients. And it could also be due to the debility related. constipation, pressure sores, muscle spasm, muscle tension, all this can also cause pain. And also comorbidities like osteoarthritis, spondylosis, etc. can also cause pain in cancer. So, suppose we want to assess a patient in pain, whom should we ask about the pain? Whom should we ask about the pain?
A doctor, a nurse,
No. Whom should we ask about the pain? Suppose a person comes to you in pain. Whom should you ask about the pain? The patient or the caregiver? Whom should we ask about the pain?
कोई भी पूछ सकता है ना, डॉक्टर भी है, नर्स है ना। इसमें तो
No.
आंसर इसका गलत बता दिया।
No, my question was not. I was asking, who should you ask means, suppose a patient comes to our OPD in pain. Should we ask about the pain to to a patient or to a caregiver? I mean, whom should we understand more about the pain from?
पेशेंट खुद बताएगा जी।
Patient खुद बताएगा. So why do you think,
numerical rating scale?
yeah, whom should we ask about the pain? Why not the caregiver? I mean, the person who has come with the patient. Why can't we ask them about the pain? Why do you think it is appropriate to get it from the patient itself? Or is it appropriate to get it from the patient itself?
It's relative also.
So it is always recommended to ask the patient about his or her pain. Why? No one else would be able to explain about the pain so well as the patient. Unlike other symptoms like breathlessness, nausea, vomiting, all this we can see the patient and understand some, but it is very different in the case of pain. Pain, you will have to directly understand in detail from the patient itself. So always remember, as much as possible, always ask the patient about his or her pain and not the proxies or the family who is accompanying the patient. Always try to understand more about pain from the patient itself. How do we do pain evaluation? So, first we'll have to take a detailed history of the, how do you do evaluation in your setting? Can somebody unmute and talk? How do you evaluate pain?
Ask the patient at what specific part you feel pain और कब से है।
Yes.
By
कितना
patient facial expressions.
जी जी कितना
Facial
स्टेपिंग
expression.
पेन है या सिंपल पेन होता है, रात को होता है, सुबह होता है।
Yes.
These all things we ask from the patient.
Yes. Anyone else want to add something more to that? What Vikas has
Rating
said?
scale.
Pain scales.
Yes, we can use pain scales. So, how do we evaluate the pain? So, first and foremost, detailed history
Examination,
taking is,
investigation, detailed history.
yes, detailed history taking is very important. As in any symptom evaluation, we'll have to take a detailed history of the patient. Then we will ask in detail specific questions related to the
online.
pain.
3 से 5 बजे तक करवाएगी।
Sorry. Sunita, you were telling something?
No, ma'am.
Okay. Okay. So first of all, we do a detailed history taking. Followed by that, we'll do specific questions related to pain. Then we will have to explore other symptoms. So not only pain, the patient might be having other symptoms also. So that also need to be explored, and including the total pain concept. That is, the psycho, socio, and spiritual suffering should all be included while exploring about the other symptoms, as well as examination, then followed by needy investigations. So the evaluation would include detailed history taking, then specific questions that are related to pain, and also explore other symptoms other than pain, and covering the total pain concept. All the 4 aspects of pain should be addressed. Then examination followed by investigations. So how do we do history taking? What all points we should remember while doing a history taking? Can somebody, what all should we remember while taking a history? You might have, all of you might have taken history of patients. So how do we do history taking?
Just
By
like now,
subjective data or by objective data?
Pain location.
Huh. Yes.
Pain location or
be calm while asking any question to the patient,
Yes, very good.
or just like no open-ended question. Yes, explain how and where you feel such type of pain.
Anyone else wants to add more to Vikas?
Ma'am, location of pain.
Okay, location of pain. So we'll be talking in detail about the specific questions to be addressed related to pain. So now, when you take a history taking, there are different methods by which we do history taking, but very important is something which Vikas has also pointed out: active listening to the patient. Make sure that you don't interfere in between. Allow them to talk, and also don't forget about the comorbidities and the drug history. So these are some of the points that I would like to highlight while taking the history taking. Is while you do the history taking. So most important is that give an active listening to the patient. It's not like you are very busy with your documentation and keep on documenting and the patient is talking something. No. Listen to the patient well. Then only you do your documentation. You understand and address their concerns. You try to understand their concerns and listen to them. And once, don't interfere in between. So sometimes maybe we have some points to be collected. When that is done, we said, okay, fine, over, done. No, we shouldn't do that. We should not interfere in between. We should let them talk and explain. Then after that, we should do the documentation part. And also comorbidities and drug histories also should be detailed and should be documented. So we said specific questions related to pain. What are the specific questions related to pain? So when we are going to assess pain in detail, what all should be assessed? Any idea? So location of the pain. We need to understand the location of the pain. So we have a mnemonic for that. Then duration of pain. So when we have to assess where the pain is, actually where the patient is having pain, and since how long is the patient on that pain. So that is the duration of pain need to be documented. Then palliative and provocative factors. What does that mean? Palliative and provocative factors? What are the factors that increases the pain, provocate or increases the pain? What are the factors that reduces the pain? So that also needs to be documented. Suppose a patient says that pain increases on coughing. Sometimes people say that they have pain relief. When you assess a patient on pain and the patient says that when they apply analgesic gels, they get pain relief. So that we need to address. What is giving them palliation or what reduces their symptoms and what is aggravating or increasing their symptoms, provocating. So that needs to be explored. The quality of pain. What is that? Quality of pain. Is it lancinating? Is it stinging? Is it stabbing kind of pain? So what kind of pain is the patient going through? Radiation. Whether the pain is located in a place or it gets radiated to other. Why do you want to know about the radiation?
Like appendicitis, pain radiates to like region, or kidney stone pains start from front to radiate backside.
Yes. So the radiation of pain, it is important to know the radiation of pain to identify the type of pain. So if it is radiating along the distribution of the nerve, then what does that mean? There is a neuropathic component to that pain. So to understand more about the type of pain, we need to assess on the radiation. Severity. So somebody told about the scales. So intensity or severity of the pain needs to be documented. So it is important to document the severity of the pain. So that is, once you document the severity of pain, then only you will be able to assess if the patient is having better relief or if the pain is worsening. So to understand that, the severity of the pain also needs to be documented. What are temporal factors? So the temporal factors means how often the pain comes back or how long the patient is having relief. So that is how frequent the pain returns. That is temporal factors. And the impact on ADLs, how the activities of daily living is being affected. Is he able to do his activities of daily living as before, or is this pain affecting the activities of daily living? So that is also important to know. And the meaning of pain. What does that mean by meaning of pain? Can somebody give any comments on meaning of pain?
It can
Means
be spasmodic or continuous.
Yeah. So the meaning of pain means how this pain has affected the whole existence of the patient, how the pain has influenced the patient as a whole. So that is the meaning of pain. So sometimes the patient might think that if the pain worsens, then that means that he is nearing his death. He is deteriorating. So what does he understand or what does this pain mean to him? So that is the meaning of pain. That also we need to explore. So this is a mnemonic that we use in our settings for assessing the pain. LDPQRST. L is location, D is duration of pain, P is palliative and provocative factors, Q is quality, R for radiation, S is severity, and T is temporal factors. And also the impact on ADLs or activities of daily living and the meaning of pain need to be addressed. So this is a body chart. So just to show you that how you can document pain in a better way. This is a patient with multiple pains. So their pain, the pain is being documented. So the location of the pain as well as if the pain is a localized pain or is there any radiation can be identified from this picture itself. So this is a very good way of documenting pain that we use in our settings. It's a body chart. And along with that, you can also record the severity of the pain also. So that helps. How do we measure the severity of the pain? What all you were talking about the pain scales before. I remember someone was talking about the pain scales. Are you familiar with the pain scales?
Yes.
Have you been using any pain scale or which pain
Yes,
scale are you
ma'am.
familiar with?
Visual analog, numerical scale.
Okay. Are you using it, Shani, in your setting?
पेन स्केल में फेशियल एक्सप्रेशन देखा करे ना.
Yes,
Yeah.
we have.
My mic was not opening. Yes, we do use in our setting.
Okay. So we'll be talking about the pain scales. So depending up to measure the intensity of pain, they use pain scales. Pain scales can be unidimensional or multidimensional. When I say unidimensional, we are measuring only the physical component of pain. Multidimensional includes the emotional component of pain is also being evaluated in multidimensional pain scales. And this include McGill pain questionnaire and brief pain inventory. The unidimensional pain scales, which is only measuring the physical component of pain, there can be verbal and non-verbal pain scales. And the verbal pain scales include numerical pain rating scales, visual analog scale, and categorical scale. And non-verbal pain scales include von Becker's FACES pain assessment scale. Okay, so this is a numerical pain rating scale. So we have a pain rating scale from 0 to 10. 0 is the no pain and 10 is the worst imaginable pain. So depending upon the intensity of pain the patient is undergoing, you can ask the patient and record it in the numerical pain rating scale. So do you think it is important to record the pain score? So Shani, you said it was being used in your setting. How was it helpful?
Yeah, even this morning we were visiting the patients, and I had to use for an illiterate person a improvised form, like using them 25 paisa, 50 paisa, 75 paisa, like that.
Okay.
And to know their current pain, and when they take medication, the patient, when they're given pain medication, how much improvement was there. To know that we were assessing. So to know the progress, to diagnose, it is necessary.
Exactly. Thank you, Shani, for that. So, especially to understand the progress. So, if the medication is helping the patient and how far the patient is having pain relief, or is the so to assess the progression, we need the numerical pain rating scale is helpful, or the pain scales are helpful. Then we have the von Becker's FACES pain rating scale. So that is a non-verbal scale. So that is from 0 to 10. 0 means no pain, no hurt. And 2 means hurts little bit. And 10 is the worst hurt. So it is 0, 2, 4, 6, 8, 10 scale. And this is used to, it's a non-verbal scale that is used to measure the pain. So we have the categorical scale, which shows no pain, mild, moderate, severe, and excruciating pain. So that is how the categorical scale is. What are the principles of pain management? So the principles of pain management includes treat the treatable. most important is treat the treatable. Then non-pharmacological management and pharmacological management. What do you mean by treat the treatable? So
The
what
the condition cannot be totally cured. The pain can be alleviated so that the quality of life could be improved.
Yes. So that is how. So the quality of life can be improved with the symptomatic management. So suppose the patient is having a tumor, and if a chemotherapy or radiotherapy can shrink the tumor, it is always advisable the patient to undergo the curative treatment. So always treat the treatable conditions whenever needed. Suppose a patient is having severe abdomen pain and you find that the patient, it is due to the constipation, obviously bowel clearance can relieve the pain. And also conditions like diabetes, when a patient is suffering from diabetic neuropathy, it is very important to have a good control of the diabetes for improving the pain relief. And also in case of fractures and all, along with the analgesics, the most important is the stabilization of the fracture. So whenever indicated, treat the treatable is what is the first step in the principle of pain management. And the next is non-pharmacological management. So the non-pharmacological measures like TENS, transcutaneous electrical nerve stimulation methods, hot and cold applications, ultrasound therapy, relaxation distraction techniques. So all these are the non-pharmacological measures for pain management. And the pharmacological management. So what are the principles of analgesic use? So always, whenever possible, provide medications or analgesics by the mouth, by the clock, by the ladder, and individualized treatment. What does that mean? By the mouth? What does that mean by
Oral
by?
medication. Or whenever possible, start with oral medication.
Yes. Very good. Whenever possible, start with oral medications. By the clock, what does that mean? By the clock?
टाइम के
Throughout
ऊपर दीजिए
Right time.
By the clock?
राइट टाइम
Right time.
Prescribe drug according to their duration of
दिन में.
action.
Yes, very good, Mamta. Always do the prescription. Optimal prescription should be given as per the duration of action. So, suppose you start the patient on a.
By the letter का मतलब क्या है भाई?
Yes, yes,
Then
Sunita,
थोड़ी
I'm coming to that. So by the clock means always provide the medications as per the duration of action. So suppose a patient is being started with paracetamol. Is there a point in giving paracetamol 500 milligram once daily for a person and telling that there is no adequate pain relief?
no.
No. So what is the duration of action of paracetamol? So it is
4 to 6 hours.
6 to 8 hours. So we need to provide paracetamol in that frequency, either 8 hourly or 6 hourly for adequate pain relief. So that is what is meant by the clock. And by the ladder, what does that mean? You were talking about that, Sunita. You were telling something
According
about
to
that?
severity of pain.
Yes. According
You
to
add, you add on adjunct therapy with the WHO stand guidelines.
yes,
That is
yes. Yes, Shani, thank you. Thank you for that response. By the ladder means depending upon the severity of the pain, WHO has proposed a ladder, a WHO analgesic ladder for cancer pain management. So prescribe the medications as per the WHO analgesic ladder for cancer pain management. So that is what is meant by the ladder. And individualized treatment. So always the treatment should be individualized. Each person is different and each patient need to be assessed and treated according to their symptoms and according to their needs. The
Choose
patient,
right drug, route, and doses based no morbidity.
yes, exactly. And so this is the WHO analgesic ladder that we were talking about. So the patients with mild pain can be started with step 1 analgesics, which include non-opioids plus or minus adjuvants. If the pain is more, then we escalate to step 2. Step 2 includes opioids for mild to moderate pain, like tramadol, tapentadol, plus or minus non-opioids, plus or minus adjuvants. And if the patient is having severe pain, then escalate to step 3, which includes opioids for moderate to severe pain. That is, step 3 opioids include morphine, fentanyl, methadone, plus or minus non-opioids, plus or minus adjuvants. So always you prescribe the analgesics as per the WHO analgesic ladder. And what is our target of pain control? To produce satisfactory pain relief, that is pain-free during the sleep, pain-free during rest, and pain-free during movements. So that is what we are trying to achieve. And always set realistic expectations. Don't give false hopes.
Oi,
So I think that brings me to the end of this session.
Thank you, Dr. Amirtha, for the wonderful presentation. Anybody have any doubts or clarification regarding this topic, please ask.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am. Thank you, sir.
So I think they all very well understand about pain now. So nobody's have any questions. So I think Sangeeta, am I audible?
Yes, Shiba, please go ahead.
Okay, thank you. So Today we have discussed many things, especially pain. So we all nurses, we need to understand that this is one of the most important symptom because most of the time the nurses are spending time with the patient because we are the asked person to assess pain and based on our assessment or doctor's assessment they will plan the treatment, no? So the assessment is very, very important. So the assessment thing, the um, steps also madam has mentioned very well. Always remember LDPQRST so that you won't miss anything if you do like that. So we know the pain is the fifth vital sign. So we need to do the proper assessment and document it well. And also if the patient is having analgesics, when again when they come to the follow-up, you have to assess. You are the person to reassess the patients in palliative care, especially Pallium India. We all nurses will be doing the assessment part, all assessments. So you have to understand well. If you know the details, then you won't miss anything. If you do the proper assessment, you can able to plan better treatment and then the patients will get benefited. So our main aim is to give satisfactory pain relief to the patient. So the second most aim of palliative care is to relieve pain and other problems. If you are able to give a proper symptom relief, definitely we can able to improve the quality of life. And also you have to keep it in mind the total pain concept. If they have a psychosocial issues, the pain intensity will increase. So you have to give proper attention to the other aspects. If they have a psychosocial issues, you have to listen their psychosocial issues and explore their problems. If you are able to explore their problems, you can give something. You can if you are okay, if you are able to do something for that, you can able to you can give or you can connect with someone. For example, if you have a psychologist or a social worker in the team, you can connect with them. Otherwise, you can connect with the other palliative care team so that the patients will get benefited. So we are working for the patient's purpose. No, so our aim is to improve the quality of life and satisfactory relief. So if you have seen these kind of things, you have to give total attention to, so that is total care from the beginning, that last day onwards. So we have learned about the total pain concept and total care. So the palliative care is also focusing on the total care aspects, that is physical, emotional, social, and spiritual. If you are able to look into these, give a attention to the four aspects, definitely we can able to improve the quality of life of the patient and their family. Okay, thank you. We have another session on management of pain, 2 session upcoming days. So that day we will discuss about the management of pain. Now you all thorough about the assessment of pain and all, different types of pain and all. So Sangeet, video study or not?
Yes, ma'am, we can play it now.
Okay, we have a video on assessment of pain. Please watch on that video and let's see if you have any doubts in the meantime, please put it in the chat box. Thank you. Amirtha ma'am, anything you want to add?
No, Shiva, I think, no, I would like to take up any questions if they have, but let's watch the video and come back.
Okay, thank you. Thank you. I hope the assessment is clear to everyone now. So any questions? If you have any questions, we can take it. Otherwise, we can wind up. Unfortunately, we don't get any patient story today for the presentation, for the discussion. So if you come with the patient story along with the presentation, so that is the good way for learning many things, because the faculty will be presenting the theoretical part. At the same time, if you come with the similar patient story, you can connect with the theoretical part and discuss more, so that can be that way we can learn many things. So the next I have a small request to everyone. Next day onwards, please come with the patient story, because Sangeet is the person to coordinating this course. So you please share your patient story with him as early as possible. We need a patient story for discussion from that. Thank you. Can we wind up, ma'am?
I think so, Shiva. I hope the video was clear to all, and you might have at least thought about some of the assessment points. When you went through the video, you might have had an idea of some of the assessment points. I hope so.
Yes, ma'am.
Yeah, and if we don't have any questions, I think Shiva, we can wind up.
Okay. Thank you, Amirtha, ma'am, for the
Okay, ma'am. So at last, one more thing.
Shiva, ma'am, your voice is breaking.
So one more thing. So I would like to highlight here is always you have to believe the patient words. That is very, very important. What about now?
Yes, better, Shiva.
What about now?
Better. Yes, I think that is a very important point that Shiva has told.
What about now, Sangeet?
Yes, ma'am.
Okay. So the final, yeah, okay, yes. So
I think Shiva is having some network issues, but yeah, I do want to emphasize the point what Shiva was trying to talk about. Always believe the patient and always try to assess from the patient. So it is very important that believe the patient, and pain is what the patient says. So I would say that that would be the best takeaway from this session. And thank you all for the patient listening.
okay, thank you. Thank you, ma'am, for the wonderful presentation. Thank you.
Thank you, ma'am, for the wonderful presentation. Thank you, Shiva sister, for facilitating even when you are sick and in a low bandwidth. Thank you for that. Thank you all for participating as well. Thank you for making it an interactive sessions. Do come with a patient story on next session onwards. I am hoping from every participant. Thank you. Let's see in the next session. Thank you. Bye.